Hi, everybody. We're just waiting for people to come through. But I think we will make a start because you never know how long people are going to take to dribble through. So good afternoon and welcome to our panel discussion, Leading to Demonstrate Impact, How to Use and Influence Data Collection. I'm Elizabeth Taylor and I'll be facilitating today's session, and that's part of my role in RCOT in developing a culture where everyone feels confident in using data and evidence to demonstrate the value of what we do as occupational therapists. So in a minute, I will introduce our panelists and explain how the structure of the session will work. But first of all, I'm going to hand over to Karin Orman to set some context for today's session.
Hello, everyone. I'm glad that you could join us. So I'm Karin. I'm Director of Practice and Innovation at the Royal College of Occupational Therapists. And 18 months ago, we launched our workforce strategy for occupational therapy, looking at where we should be as a profession from 2035 and beyond. And we are delivering the strategy through 4 strategic priorities. The first being optimizing OT, second, demonstrating value and impact, retention and career development, and then finally, effective workforce planning. Outcome measures link all of these priorities. Capturing impact not only informs where and how occupational therapy should be positioned across the health and care system, but it also evidences how we can make a difference to improving people's lives and well-being. Outcome measures also inform the level of experience and expertise we need within a team or a service. And then capturing the results boosts our confidence, morale, and motivation as a profession. So, this time last year, we ran 2 workshops posing the question, could we have one outcome measure for occupational therapy? To build our data and our evidence base, it was a good question to ask, but we know that there's not one golden outcome measure for the profession. But we can collectively explore at a regional level or perhaps a specific population level, like stroke or dementia, applying and collecting the same outcome measures so that we consider how this builds our evidence base. So I'm really looking forward to this panel discussion about applying outcome measures, thinking about how we measure our impact, how do we consider what a difference we're making across the health and care system at a system-wide level, and hope this will lead through our practice networks and our COT communities further discussion. OTs discussing at a regional level or a specific population level, thinking about how we agree a set of outcome measures, what data is already being collected, how can we build on that, where can we influence that data collection, but also just then unpick sort of, if we agree to work on on capturing a certain type of evidence, how do we do it? How do we evaluate and how do we report and inform? And if there is service already taking this approach, if you listen to this panel discussion and go, oh, we're doing something similar, we're doing something different, please come and bring this forward and share this experience and the progress that you're making with the wider group. So I'm going to stop there and sit back and enjoy listening to our panel members.
Thank you, Karin. That context is really useful. This is the second of a pair of panel discussions that we've had on outcome measures and demonstrating our value and impact. The first one focused more on how you can choose the right sort of data to collect. So if you want to catch up on the recording from that, it is on our website. But we've heard from our OT leaders that you're ready to move on from questions about why we should collect outcome measure data to really practical conversations about how we translate OT specific data to a wider audience of strategic decision makers. So that's what we're really focusing on today. We have 3 exceptional panelists who will represent 3 different spheres of influence, from health board operations to strategic systems leadership to government policy. And each of them will share a specific example of using data to influence decisions in their context. So please do introduce yourselves in the chat, ask your questions in the Q&A box rather than the chat box. And if you thumbs up any questions that you want us to prioritise that someone else has asked, then that would be helpful. We're going to be leaving plenty of time today for discussion after we've heard from our panellists. If you're typing a question in the Q&A and you want to address it to a specific panellist, just make sure you put their name in there so that it's easy for me to field it when the time comes. And use the reactions as you go along. If you're not familiar with Zoom, have a look, see if you can find thumbs up and heart, and you can perhaps give it a go now for practice, because it really does help boost the energy in the virtual room when people do that during the session as well. And don't panic if you're not used to being in these Zoom webinars, you are automatically muted. So don't worry, we can't hear you if you're having your lunch. So, the other thing to mention is that we've started a discussion in the Leadership Network part of the RCOT Communities platform, and we'd love members to carry on the conversation there after the event, and the link to that will be in the chat as well. So, without further ado, I'll introduce our panelists. Susie's going to pop their full bios in the chat, so I'll just give brief introductions to each one. So we've got Rob Workman, who is Deputy Head of Occupational Therapy at Swansea Bay University Health Board in Wales. Rob's career journey from OT assistant through clinical leadership to his current role gives him really grounded insight into what data matters at health board level. He's passionate about workforce development and bringing OT evidence to operational decision making. And we have Kate Lowson, who's Care Group Lead Occupational Therapist for Renfrewshire and Inverclyde Health and Social Care Partnership in Greater Glasgow and Clyde. And Kate is co-chair of the Scottish National OT and Primary Care Network. And over 3 decades in mental health, Kate's become nationally recognised in Scotland for leading impactful projects that influence government strategy. So she's an expert in connecting data with clinical practice to drive change at systems level. And last but definitely not least, we've got Dr. Jenny Preston, MBE, and Jenny is a consultant occupational therapist specialising in neurology, and she holds influence at government policy level in Scotland. And Jenny still manages to combine clinical practice with research and strategic planning, and has a demonstrated track record of translating occupational therapy evidence into policy change. So really excited to hear from them all today. And the plan is that we're going to hear 3 real examples of using data to influence decision at different levels. And I should mention that all our panelists have a wealth of experience to discuss, but I have asked them to focus on one example to begin with to keep us nice and focused. So each panelist will address the same 3 questions. They'll tell us about what they were trying to achieve, what they did, and what happened. So Rob, I'm going to start with you. I think you have an example to share with us of how you used outcome data to develop an OT service in GP practices. So can you tell us about that experience?
Yeah, brilliant. Thank you. Good afternoon, everyone. Brynham da pawb. So yeah, that's quite right. I'm going to use these few minutes to explain really a practical example of what we did to develop an OT workforce in GP practices in the Swansea Bay, Neath Potaba area. Got 8 clusters, and there was no OT in any of them until a couple of years ago. So from a strategic perspective, in Wales, there are quite a number of drivers that are encouraging us to move into the community. A Healthier Wales is the overarching document, the strategic programme for primary care model for Wales, as well as an encouragement to move services into the community to be delivering them closer to home for our residents. Also, part of that was a real focus on enhancing the multidisciplinary offer that is based particularly in GP practices in primary care. And the challenge for us with that is that we didn't have any OTs working in primary care. There was some really good work being done across Wales and other health boards, but nothing in Swansea Bay. So we met with all the GP practices and we told them how amazing OTs are and what we can do, how adaptable we can be to their population health needs. We thought they would jump at the chance of funding us with the money that they get every year. And we were quite disheartened to find out that they weren't interested at all because they didn't really know about OT. They didn't understand what we were telling them, and they weren't going to take a punt on us with money that they had lots of use for the small pot of money they were getting for this kind of development, and they didn't feel that we could articulate what we could offer them. We even linked in with some of our colleagues working in other health boards who were doing it already to explain what they were doing. But what we found is the GPs weren't really that interested in what was being done generally across the board. What they specifically wanted to know is what were we going to offer and what would the impact be on the people living in their locality. And of course, we couldn't tell them that because we didn't have any data to to demonstrate that impact. So we had to rethink what we were going to do. We went back to the drawing board, and as a senior leadership team, we just scoured our core budgets. We got a little bit of money from here, there, and everywhere, managed to get enough money for a full-time band 7 OT, went back to the 8 clusters and said, we're going to pay for this. We just want one of you to host this service, thinking that, again, they'd all jump at it. They didn't, because they still didn't know. Thankfully, one of them did, and that was it. That's all we needed, was one GP practice to say, yeah, if you're going to pay for it, it's not a loss for us. Let's see what you can do. And if it doesn't work, we'll draw a line under it in a year's time. So I'll just run through the data that we use, the outcomes and the data we use for evaluation. Number of referrals, including the referral details and reasoning. That allowed us to target those GPs and those practices that weren't referring to us, so that we could find out why, and then we could go back to them and do some marketing with them, and increase the referrals. And we did see over time, even though GPs were a huge referrer, other members of the MDT started referring to us, and even got to the point where, when service users knew about us, they were actually contacting to say, I don't want to see the GP, I want to see the OT. So they were self-referring to us. Interventions completed and onward referrals made. Again, that was able to demonstrate our role when we were doing our evaluation report, but also identify gaps in service that we could plug. So, for example, we might be referring somebody onto secondary care and putting them on a waiting list for pain management, when in fact we could do some of that ourselves. So at least give them give them a bit of more of a positive outcome while they were waiting for more specialist services. We did use we wanted to use some OT specific outcome data. So we used the OSTOMs, which is a rating scale that includes function and distress levels. But it was great, but we found that we couldn't articulate. People weren't interested in it. As soon as we started saying it's an OT specific one or a therapy specific one, people were switching off from it. So we moved on to the Bartel index, because people were familiar with it. And if we're using outcomes to try and demonstrate what we're doing, we need people to understand it. And I should say, from this perspective, I should have said at the start, outcomes are more for the service users, but I'm talking at this from a service development perspective. So I'm focusing more on how we used it to articulate what the service is, to develop that, rather than the patient aspect of it. But of course, it's all linked together. We use the EQ5DL, quality of life scale. We stopped using that quite quickly, because as a quality of life scale, what you really want to do is do that repeatedly over a period of time to make sure that what you've done is actually having a long-term impact. The nature of this service, it was brief interventions. We didn't have the capacity to be following up on with patients afterwards. So as a result, from a resource perspective, that wasn't an outcome measure that we could continue to use. We thought savings would be a really good focus. We calculated the frequency of contacts with GPs 3 months prior and 3 months post to see if there was a difference there. That was complicated because they could be going for different reasons. So it wasn't really, it's like comparing apples and pears, because they weren't going for the consistent reason. And also, that was an assumption we made, and we found out GPs were busy, but they weren't interested in reducing the number of people they saw. They were more interested in making sure that the people that they saw were seeing the patients were seeing the right people. And if that was them, so be it. They should be seeing a GP. But if they had more options, and the OT was the best person to go to. So it wasn't about reducing the number of people going to the GP. It was about triaging them and making sure they saw the right person. And this is what we learnt as well, that we were also saying, because part of it was about preventing admissions by nipping the issues in the bud in the first place. We were very keen to focus on how many potential admissions to secondary care that we had done. We were shooting ourselves in the foot, because then suddenly we were asking the GP practices for money for this, and they were saying, well, if you're actually saving money for secondary care, why aren't you going to them to pay? So you've got to be really careful with outcomes, that you are actually presenting data that might be useful, but actually you are going to be doing yourself a disservice in some cases. We found out that absolutely what was essential was GP and patient feedback. That qualitative data about what they felt we were offering. And that has really moved on in more recently, that we use case studies and patient stories as feedback, particularly when feeding back to GPs, for example. They have so much data, so many figures, so many spreadsheets. We found out that they actually really appreciate having a narrative about this patient came in, this is what we did, this is what happened to them, and this is what the outcome was for them, and this is what they thought about it. And providing that, it gives an emotional attachment to that patient, but also it was a bit of a break from them from looking at all the facts and the figures and the charts, which was really useful. So very quickly then, what happened next with the use of all that? In 2018, we started with one band 7 OT, which we funded ourselves. Very quickly, I was approached by another cluster. They had money, they wanted an OT, they'd read our evaluation reports. They had started talking to each other about what we did. Very quickly after that, I had an email from the medical director who had money from Welsh Government for a multidisciplinary virtual ward. She wanted OTs because she'd read our evaluation reports. I got funding for 8 full-time OTs to work in that service initially from our reports. And now, 5-6 years later, it's still happening. I've just submitted 2 more proposals to 2 other clusters that now are approaching us to say, we can see all the great work, we're hearing about all the great work and the impact of OTs, and we want you in our team as well. So what can you offer? So I suppose from that, what we've learned is we've needed to adapt the outcomes that we're using and how we present it to our audience. Keep an open mind about what is an outcome. We were very focused, it had to be a standardized OT specific one. That didn't work for us, and it was very much more the broader outcome data and the qualitative narrative data that was having most impact. And realistically, yeah, I suppose my final point is to just keep that open mind about it, and be patient, because we're still seeing it. We started this process 8 years ago, and we're still developing our service based on the outcomes that we've been developing and keeping all the way through that period. And we're really excited about what's going to happen. We'll be happy till we get an OT in every single cluster in the region, and we're at 4, so we need to get another 4 now. And I think we will. I'm sure we will. Thank you.
Rob, that's amazing. You've got loads of wow style reactions in the chat, and that's how I'm feeling about it as well. I think what I love about hearing that example is that quite often we feel like we need to bend ourselves into reporting on stuff that will mean more to other people than it does to us. But your story shows that actually you've gone through that process and realised that those qualitative stories are the ones that people wanted to hear, as well as the other things. So that's really, really interesting. There is a question for you in the Q&A, just a reminder of what the OT specific outcome measure you used was before you moved on to the Bartel. I think you said OSTOMs.
Yeah, it was the OSTOMs that we
And
used.
was there a reason you'd gone for that one at the time?
I think it was when we tried to, we'd been doing the same kind of stuff in our service, trying to find one that everybody could use, so that as people were moving around the service or patients were moving around the service, it would be something consistent that could follow with them. It's also quite a holistic one. There's elements of function, but there's also elements of distress and carer distress. So it is a very holistic one. And it is a good one, and we do still use it in some of our services. But for this service, because we were, as I say, because we were trying to articulate that to an audience that didn't know about OT, it wasn't having the required effect. Although we were finding it useful, but then from a resource perspective, we were already gathering lots of data, and we had to make the hard decision. And we were really focused that we wanted to use an OT specific one because I think it's really important. But that's another assumption, that we have actually managed to show what OT does without using an OT specific outcome, which I think is really freeing. It's about how you articulate and interpret the data rather than being too focused that it has to be OT specific. That made
What a
a huge
fantastic
difference for
message.
us.
So if there's anybody listening who's thinking they know that there's something that would work really well, they've got that motivation like you had to put OTs into a new service or whatever it may be, what would be, I mean, this has been 8 years work for you, but what would you suggest would be a good starting point?
Um, I think it's got to start with a need. So depending where you're wanting to put that service, there has to be a need. So you need to have that data to start. It might be a strategic need, so something in a document, whether it's a nice guideline, whether it's actually something from the government saying what needs to be done. There is population health data available across the whole of the nation. You can get hold of that. You can actually see where there are pockets, where there are particular issues that you think an OT could help with. And if you're in a leadership position and you have access to it, and most of them are most of these documents are in the public domain anyway, is IMTPs, annual plans. Because if you're trying to set up a service and you're trying to get money, the way that that works is unless you're in a top priority area, the chances are you're going to get bumped down the priority list for funding. Look at the IMTPs for your organization. Look at what the main priorities are and see whether that correlates to what your service needs are and what you want
Fantastic.
to achieve. And if you can do that, that's the golden relationship. If you've got a service and you've got the population health need for it and you've got an IMTP high priority for it, then that gives you a starting point to try and say, we can do something about this. And then you've just got to keep plugging away at it. Really just keep plugging away. And I was at another event a little while ago, and somebody said, "Oh, I've been trying," and someone put a comment in saying, "I've been trying to get a service going, and I'm losing the will to live." And I would say, we've all been there, but just keep plugging away and gathering your data and writing reports and talking about how amazing OTs are and what you can do, because somebody will listen, and it could be a year. Like I said, I'm getting the proposal now 5, 6 years later, because it's taken that long for services to be in a position to say, do you know what? Yes, we've got a bit of money now. We've got a bit of money, and we've been waiting to be able to say to
So
you
keep
guys,
going.
yes, we want you. So just keep going and don't lose faith, really.
That's great. But one more very quick question before we move on to Kate from Ashling, who says, did you continue with an OT specific one for your own analysis? So some of that information that you realised wasn't so useful for the other audience, have you carried on collecting the data anyway?
We didn't, and that would be the ideal. It comes down to resource eventually, because all of these things take time, and unless you have a workforce that is big enough to be able to gather all this data, it's really tricky to do it. So, like I mentioned, we had to make the really difficult decision that we couldn't do the OSDOMs as well as the Bartel, as well as something else, because the number of patients, it seems easy to do because none of them take that long, but actually, if you've got a high turnover of patients,
Yeah.
that is an awful lot of time that you need to do, and you need to process it, and then you need to evaluate it. So unfortunately not, but that would be the ideal.
Wow, that's been a brilliant start. Thank you so much, Rob. We're going to move on to Kate now. Kate, I think you're going to talk a bit more about the strategic systems level influencing using an example from dementia. So in that context, let's hear about your experience of demonstrating the value of occupational therapy.
Yes, and thank you so much for the kind invitation, and that's fantastic, Rob. The presentation that you gave there. I have to say I'm cheating slightly, in terms of my memory isn't that great, so I'm actually going to be sharing a presentation. Can I just check that is showing, please?
It is, but I don't think it's in the view you want it in. We've got
Ah,
the one where you get the little slide in the corner.
okay.
It doesn't particularly matter, but you might prefer to have it the other way.
Yes, absolutely. Okay. Sorry about this.
No worries. It's giving me a chance to have a look at the chat.
How is it looking now?
So we can see it in your sort of desktop PowerPoint view with the slides down the side.
Oh, for heaven's sake.
So Kate, if you press slideshow at the top, it will give us
Yep.
the full view.
And Kate, your bio's just gone into the chat, so people will be taking
Lovely.
a second to read that anyway, so no stress. There we go, perfect.
Hopefully it'll move. I can't see my notes, but that's okay. I'll wing it. So thank you for that. So my name's Kate Lawson. I'm Care Group Lead. I'm based in Greater Glasgow and Clyde. And when we were talking about what we were going to speak about, when we were only allowed to give one example, I felt that the piece of work that I wanted to come forward with was regarding dementia in Scotland. And just to give a bit of context in a national view and then locally, at the moment there's an estimated population in Scotland of 5.5 million people. And I don't know if this is going to work. So when we look at some of the population data in terms of people living with dementia, in 2019 there's an estimated population of 65 to 92,800 people, with females accounting for approximately 2/3. And when we look at prevalence rates, so these are coming from various different sources, but this particular source is coming from the Scottish Burden of Disease study, which was published in June 2025. And you can see that there's a 52 to 58% increase of prevalence of people living with dementia compared to 2019. So that's to give you a bit of context of why does occupational therapy need to think about what we are providing or how we are supporting people living with dementia. One of the areas that I'm responsible for is an area called Inverclyde, which, as you can see the context there, it's near Glasgow. It's near but not there. And this is an area that is both rural and urban, with areas of high deprivation. Its source, its background was as a shipyard area, and obviously when the shipyards closed, then alcohol and drug misuse became prevalent in the area. And high unemployment rates. At the moment, the population is just shy of 79,000, but an over 65 population of over 18,000. When we looked at the prevalence rates in 2019, there was just shy of 1,500 people living in dementia within Inverclyde. In a recent study where we looked at the OT workforce model in accordance to the balance system, we looked at the population change from 2018 to 2028, and there's a 15% increase of 65 to 74 and 75 and over. So we've got an ageing population within the area as well, to give some context. Also looking at some of the national records in terms of dementia, looking at the leading causes of death in 2023, you can see that the third leading cause was dementia and Alzheimer's for males, and it was the leading cause of death for females in 2023. So this is a lot of figures, and you think, what's this to do with occupational therapy? But actually it's got a lot to do with occupational therapy. If we're looking at, the future of our workforce, we're looking at how we want to ensure that we are providing intervention where we should be. This has given us a real impact, and it's quite stark information in terms of the population's ageing, dementia is more prevalent, and are we fit as a workforce to provide occupational therapy within that? From Inverclyde itself, it wasn't an occupational therapy project, and it wasn't even an allied health professional project. It was indeed a project that was looking at care coordination pathways. And it embarked with the support of Healthcare Improvement Scotland in 2019. And believe it or not, we actually embarked through COVID as well and had a slight extension and concluded in March 2022. My role has previously been in Inverclyde as performance and measurement lead for the Mental Health Directorate. I was asked to lead up the data subgroup attached to this work, and hence why I'm sitting here today giving you a bit of information around that. So really what I want to say is you don't necessarily have to be an occupational therapy focused project or occupational therapy outcome measures. If you have the knowledge, the skills, the experience, you can go through any project, you can lead any project, and that's what today's talking about. It's talking about the leadership in terms of the difference that we can make. So this project was actually not occupational therapy specific focused, but it was actually looking at the whole care coordination for people living with dementia within a population. It's referring to the population health, looking at health economics, looking at research. And really what we very quickly did was we devised this pathway. And then what I quite very quickly did was then I looked at locally what we had in terms of occupational therapy ask and gift to the service, so that we were tapping into each section of the stages in terms of the occupational therapy input. Then, as part of the work, we were then asked, as I was then asked to endure 3 years of sitting round the table with 5 data analysts from various different backgrounds to look at the actual data itself, what we could gather, and what would be of use in terms of shaping services, and what would most importantly be of use to the individual themselves. And that's where I came in. As being a clinical lead, having a clinical background, I was able to then support the business analysts in terms of looking at figures and saying, well, what this actually means for the individual is this, or what that actually means is we had vacancies and we didn't have staff on board, hence we had increased waiting times. And part of that work was to look at the essential data sets and desirable data sets that could influence within the Scottish National Dementia Strategy. So we came up with these demographics. What we found very quickly, so the business analysts came from Public Health Scotland, they came from the Scottish Government, they came from the local area, they came from the Health Board, and very quickly we discovered that everything was estimated. There was no set there was no set example of this is exactly what the picture is. The demographics were all estimates. We assume, we look at, we gather this information, we estimate this is what the demographics are. So pulling in various source link files from different backgrounds, prescribing, accident emergency admissions, deaths, care homes, pulling in all that information, we start to gather a picture in terms of the demographics of the local area. So we felt that was really essential to gather. Costs are essential. Health economics, what's best for the individual, but what is also affordable, which is even more so in terms of the current climate that we have. And that hadn't been done before in terms of looking at how much does it cost to care for an individual living with dementia. And I've got a wee bit very quick information about that in a minute. And morality and frailty. And frailty is a huge area of concern for occupational therapy, regardless of where your specialism is. We are all, if we're looking at the older population, then frailty is a huge area where occupational therapy makes a huge difference. But morality as well, in terms of looking at people living and dying with dementia, where people died, whether they required end-of-life care, what that looked like, the burden on carers, unpaid carers, care providers. So all of those were really essential in terms of looking at the quality for people. England, I'm not quite sure, so I apologise now, but our dementia strategy in Scotland, we have a post-diagnostic support. So post-diagnostic support link workers, it's anticipated that everyone who is diagnosed with dementia receives 1 year's input from a post-diagnostic support link worker. So there's an awful lot of expectation from the government level in terms of looking at that and meeting these targets. AHPs, we have connecting people, connecting support. We're now on to our 3rd report, which is headed by Professor Elaine Hunter. who is the HP lead in Scotland. And so therefore, we are looking at things within that in terms of workforce, we're looking in terms of skill set. And so that was as a desirable. And then about personalised care itself, looking at building the care around the person and the person's needs. We provided a report which came from data from 2018-19, and this is where the health economics and the information comes in handy, because what we looked at by looking at all the link files, etc., and all the information, we were able to see that there was two sort of clear cohorts that were provided intervention within Inverclyde. There were those that were sitting in care homes, and there was people that were provided home care at home. And there was a stark difference between the cost. So if someone was living within a care home, the cost per annum was 42,000. If they were living at home and being provided care there, it was 11,000. So this very quickly gave an indicator to the Integrated Joint Board that if you provide more resource, etc., into home care, then you're going to get more bang for your buck. And also, the person in the middle of it is going to have more quality, higher quality of life. What we did find was that the dementia cohort was costing around 27.2 million. And as I say, there was a 70-30 ratio between social care and healthcare. And the expenditure of the cohort only made up 1.3% of the total population, but actually represented 17% of the expenditure in that year. So that gave some real stark information. So why occupational therapy in all of this? Well, occupational therapy filters right through all of this. If you have the knowledge, the experience, the skill set, the clinical, you're able to look at figures, you're able to look at graphs and say, right, what does this mean for the individual? Then that is absolutely critical. So all our policymakers, all our strategists, all our business analysts, they can come up with the information, but they don't actually know what that then means. And they need clinicians like us as occupational therapists who do work with people at the raw end of their health and their lives. We work with them in terms of what their needs are and their families' needs are. And so therefore we can then apply that in terms of looking at the data and saying, we need to do a bit better there, or maybe if we improve there, or are we channeling enough resources into there? And as Rob says, have we got occupational therapists in there providing intervention or providing input? Where we're going from now is that I've now been invited to sit on the Scottish Government Dementia Strategy Data Subgroup. So I now represent AHPs on that, but I'm sitting there purely as an occupational therapist because of the input that I've had. Because of the work and the recommendations we had, the Public Health Scotland are now putting together a Scottish index. So instead of having to go through various different file sources, etc., we can now go direct to them and get a less of an estimated population of people living with dementia. I also have been invited to sit in the Public Health Scotland Data Advisory Group, which will explore the potential analyses and outputs and outcomes to be reported to the future. And I link with the Scottish AHP Dementia Forum. So although this isn't necessarily outcome focused, and although it's not necessarily occupational therapy focused, it gives an example of the power that occupational therapists have that we can apply and really make a difference in terms of service provision going forward. And thank you.
Thank you, Kate. That's amazing. And it's really encouraging to hear about how you can weave the occupational therapy offer into the broader systems priorities, and then also use our occupational therapy knowledge to interpret the data. I'm not going to ask you any questions right now because I don't know how this always happens with time. Time's going far too quickly, and I want to make sure we hear from Jenny. There are a couple of questions in the chat you might just be able to answer in the chat, which would be great. So now over to Jenny. So Jenny, you've been involved in the development of policy in Scotland, and it would be really helpful to hear how you've been able to use data to guide policy formulation.
Thank you, Elizabeth, and thank you for the invitation to join the session today. Yes, I'm going to talk a little bit more about influencing at a national policy level. I often think that this can sometimes feel a little bit removed from the experience of advocating for change within the profession. And often within my national roles, I feel that I bring my occupational therapy mindset, knowledge and skills, yet I may not be directly influencing occupational therapy practice. And it's interesting to hear both Rob and Kate talk about their experiences where they've acknowledged the importance of occupational therapy, but within what sometimes feels like an indirect context. So what I'm going to do is share a little bit with you about an opportunity that I had to be involved in the development of policy within Scottish Government. So although I'm currently chair of the Scottish Government's National Advisory Committee for Neurological Conditions, a bit of a mouthful, 7 years ago, when I was the Allied Health Professions representative on the committee, we were commissioned to develop a policy framework for neurological care and support in Scotland. The framework had to be aspirational and ambitious, and it had to focus on improving quality of life and personal outcomes for those living with a neurological condition. So that felt right up my street as an occupational therapist. So I absolutely jumped at the chance to be involved. So we were tasked with creating a vision that translated into people being able to access the care, support, and information that they need that enables them to understand their condition following diagnosis and signpost them to relevant resources for their changing requirements, as well as to empower people to be equally involved in decisions affecting them in the context of their wishes, their wider well-being, and circumstances. We also needed to think about how we would measure outcomes and demonstrate meaningful change in response to the framework. Previous guidance and strategies tended to focus on a more traditional medical model, with an emphasis on access to diagnosis and medical management, waiting times, and information sharing within a clinical context. So my key role, as I interpreted it, was to represent and articulate the wider implications of living with a neurological condition and the types of support, care, and information that's required across the whole system. As occupational therapists, of course, we know that diagnosis and treatment are essential aspects of care, but so is that having access to a wide range of services, including housing, employment, care at home, and so many other factors. So my challenge was to ensure that the strategy reflected all of this with an authentic and meaningful way. So it's interesting to hear my colleagues this afternoon because I too relied very heavily on the use of case studies from my own clinical practice to develop an understanding of the day-to-day impact for individuals in addition to the wider impact. And those of you who know me know that I've always got a clinical story to tell because I feel that that's a really powerful way to share and to learn. So I was very proactive in ensuring that we accessed a wide range of data from different sources, but also ensuring that we created opportunities to hear all the voices. And that was really, really interesting. So I really pushed for what ended up as a stadium tour. So we had gigs at Hampden Park, Murrayfield, and Pittodrie in Aberdeen to engage with people who were living with neurological conditions, those who were impacted by neurological conditions, those delivering services, those managing services, statutory and non-statutory providers, the third sector, and academic colleagues. And that was just a huge step forward in terms of taking this work forward. So we invited policy colleagues along to join the sessions, and this was just a whole new world for them, but such a powerful opportunity to share. We accessed a wide range of data gathering tools to elicit the evidence, including facilitated workshops, which incorporated a broad range of views and perspectives. We relied on the evidence base to define the scope of the framework, so even being able to agree a definition of what neurological conditions included was fascinating in itself, and also to develop models of good practice, identify unwanted variation in practice, and also to think about reducing harm and waste. So we relied on numerical data from the Scottish Burden of Disease Project, data from the Scottish Atlas of Variation and Waiting Times Improvement Plan. We accessed qualitative data through the Neurological Alliance for Scotland project on lived experience. And our work was informed through policy frameworks and national guidance, including principles of good transitions, framework for action on palliative and end-of-life care, the Scottish Access Collaborative Programme, Modernising Patient Pathways Programme, National Health and Social Care Workforce Plan, General Standards for Neurological Care and Support, social care legislation, the Charter of Patient Rights and Responsibilities, and GIRFIC, the Children and Young People Scotland Act. So on the back of that, we then established a small working group to which I was invited, which was a key honour. We held a series of meetings to thrash out the key priorities within the context of all the data that we now had at our disposal. So we used the meetings to work through what we really understood by terms like shared decision making, informed choice, creating more equal partnerships and care delivery. And language is really, really important, both in our discussions, but also within the context of the framework, because this needed to be something that was accessible to everybody. So quite affectionately, I became known as the translator within the committee. And apparently that's because I was able to combine the practical, medical, academic and qualitative narrative into policy speak, and then into a language that would be relevant for anyone accessing the framework. So while this may reflect some of my own personal skills, this was undoubtedly influenced by my role as an occupational therapist, because after all, this is what we do all the time in our practice. So we published a 5-year strategy in 2019. It concluded this year, earlier this year, and the feedback has been that this was an inspirational document that spoke to all audiences. So that felt really positive that we were able to achieve that. Many people have commented on the occupational therapy influence throughout the document, and I do feel very proud of that. The framework was definitely a departure from the more traditional type strategy documents, while at the same time identifying the key priorities for action. It felt informed, relevant, and accessible. It was aspirational, and of course we weren't able to achieve all the desired outcomes. Measuring outcomes continues to be challenging, although some areas were clearly much easier to articulate than others. £4.5 million worth of funding was made available to support projects to help deliver against the framework. And there were some great measurable outcomes presented, but many of the projects really struggled with this. So what challenges came up and how did we navigate them? Well, as always, there were strong personalities with their own priorities. But I guess this is why we're all appointed to the committee. Typically, I use my skills as an occupational therapist to understand and validate a wide range of perspectives and data, and then pull that together in a coherent and representative way. Quite surprisingly, a very senior member of the committee approached me and asked me to develop the first draft, as apparently I was the only one who had the skill set to do this. Another compliment for occupational therapy. On reflection, that was based on my abilities to listen, understand, challenge in a positive and confident way, and to be truly person-centred. I was also one of the few people on the committee who had extensive clinical experience in the area and had a whole host of evidence, both clinically and academically, to draw on to support my stance and views. And again, apparently this represented validity, authenticity, and a genuine and informed desire to make change and improvements. But I think it was because I'm an occupational therapist, and this is what we do best. So what would I do differently? So probably I would be more confident from the outset, both in terms of the value of occupational therapy and in my own skills at this level. I believe that we do have a unique knowledge and ability to investigate, listen, understand, and represent the needs of our populations. Our holistic, person-centred approaches come naturally and position us well to be advocates for improvement. So don't get hung up in numerical data. I think there's a theme emerging today, isn't there? It most definitely has a place, but alongside other forms of data. And finally, be prepared to listen to other perspectives. I have gained so much knowledge and understanding through this process. And most of the time, my conclusion is that there is no exact truth, but a consensus developed from a range of perspectives. So make sure that your perspective is heard and understood in the process. Thank you.
That's absolutely wonderful, Jenny. I love that. I completely agree. And I think I'm certainly getting a take-home message from today that we all need to have more confidence in what we can bring because we know what we're talking about, and we do tend to have those skills in listening, being person-centered, and being able to translate messages in both directions. So thank you so much for that. Karin, I just wanted to bring you in for some thoughts at this stage, and then we can see if we've got any questions from everybody else. So if you haven't typed your question in yet and you've got a burning question, please do that now. Over to you, Karin.
Thanks, Elizabeth. And I'm just aware I've got sunshine coming in on my picture, which is a good thing, but distracting perhaps. I just wanted to thank the panelists and just to say to the audience, they've really demonstrated why we needed to move the conversation on from OT outcome measures. We've got to think more widely about data and outcomes. And as you say, and as Jenny quite rightly pointed out, have confidence. We need to think about where we capture the evidence for occupational therapy, but also where are there opportunities, as Kate pointed out, as Jenny's pointed out, to get involved in wider reviews of services and developments of across the system. But let's own our occupational therapy skills. It's highlight that we're doing this as occupational therapists, because that's how I think we build the momentum and the confidence to do that. So there is no golden OT outcome measure. Sometimes it's really appropriate to capture an OT outcome measure, and certainly if we're looking at building the evidence from a research point of view, then that is something we need to consider. But we've just got to think, what is the gap? What is the problem? What is the new service that we are trying to build? What are we trying to address? And then have the confidence to just consider what's the best way to capture the evidence to prove that we are meeting that need, we're filling that gap, we're evidencing the reason for rolling out that new service more widely. And then just consider wider data sets, outcome measures and OT outcome measures might be part of that, but just think more widely. And I love the point that Robert made about telling a narrative. Jenny also talked about this narrative, this storytelling. We find it all the time at a national level. You give the data, you give examples of services, and then you give a snapshot of an individual. What does that mean? Because it really helps it to translate to audiences. Don't get hung up on templates. Just think about what is it you want to achieve, and then what do you want the audience to think, feel, and do? How do you want them to act as a result of your report, your presentation, your meeting? So thank you.
Thanks, Karin. That's all great advice as well. We haven't got any questions in the Q&A box at the moment, and I haven't seen any in the chat. I can see lots of enthusiasm in the chat, but I wondered if the panelists had anything they'd like to say about each other, what they've heard from each other, or failing that, perhaps if you've got any examples of things that you found have been so helpful in your messaging, so things that you wouldn't necessarily do again because they didn't speak so valuably to the people that you were trying to influence. So perhaps if you can put your hands up, either your real life hand or your virtual hand, then that would be helpful. I know who to come to. Kate.
Yeah, I think it's just amazing how there's three very different subjects, three different influences, but the foundation and the principles of occupational therapy threads right throughout all the three presentations that we gave there, and whether it's about influencing what's happening on the ground or influencing what we want to, how we want to influence the wider, the wider population, the government, or whether it's in Jenny's representation about the research and the future and the projection and where we're going. And so I think that the key message I have is for people to be brave. Just be brave. It's absolutely, and ask questions. There's no stupid questions. What I've found in my in my experience is it's the interpretation of the information that you get. And occupational therapists are primed that we're problem solvers. we know how to interpret things. So we are just such a well-placed profession to really have a real leadership within outcome measures and data and performance, and so just be brave and just go for it.
Thank you, Kate. Absolutely. Oh, I don't know who was up first. Rob, you're on my left, so I'll go with you first.
Okay, yeah, I think that's great. Be brave. I mean, I think that's a great rule for work, and it's a great rule for life in general. I think just have a crack at something if you think you can make an impact. I suppose I mean, I would agree with what Kate said there with myself, Kate and Jenny, that they're all very different tacks of what we did, but we're all saying the same thing, really, aren't we? It's that OTs can make an impact, but you've got to find ways of demonstrating what that is. And I think from my perspective, it's getting a seat at the table. It's all very well, and it can be more difficult. We're senior leaders here. It's a lot more difficult if you're a clinician or earlier on in your career and you have a great idea. What you do with it, you really need to be in a service that fosters that braveness and fosters that ability for people to speak up with ideas. I'm under no illusions in with my own service development example there. One of the huge things for that was that we'd had in recent years a real restructure of primary care in Wales with accelerated cluster development, which means that there are multidisciplinary boards that now meet and we make decisions about what the GP cluster spend their money on. So there's an AHP, collaborative mental health, nursing. It's not just the GP, if it's Welsh Government money, it's multidisciplinary. So I'm in a position where I can say an OT could do that. You could have and therefore AHPs, other colleagues as well. But you have to have somebody with a voice that is going to shout about what you can do. So my advice would be find out who that is in your department. Make sure that you've got that pathway to raise these good ideas, because unless you've got somebody at a senior level that is championing you, it's probably not going to go anywhere. And that is absolutely, and leaders need to know. We all rely on our staff because they have fantastic ideas and we need to know what they are so that we can do something about it, quite frankly.
Brilliant, Rob. And you preempted the question that I was going to ask if I had asked it. So perfect. Thank you. And Jenny.
Thank you. Yes, I would just reiterate what everybody else has said, and it's fascinating. And I think in my own experience, I've always thought that everybody else had the answers, that everybody else was much more skilled, and that I didn't have anything to bring to that conversation. And Rob, it's really interesting. I completely concur with you that some staff at all levels within our organisations have really good ideas, and are probably way better at collecting data than I am. And I reflect on my own career and think, so where did I get the opportunities and how did I come to be here today? Quite frankly, talking about experiences that I've had. And I think that it's about confidence, but it's also about curiosity, isn't it? So, the more curious we are in everything that we do, then the more likely we are to ask questions. But I think one of the key things for me throughout my career has been that often you go into a situation and I think I'm going to be the least informed, I'm going to have least knowledge, I'm not going to have the information, I'm not going to have the data, I'm not going to have the evidence. And then you get in a room and you think, really? Do other people not know that? Well, I know that, and not because I'm being arrogant and conceited, but because I think as occupational therapists, that's who we are, that we tend to think that everybody else will be much better informed. And certainly the experience, writing the strategy was enlightening for me in terms of the shared experience within that committee. And there were people in very senior roles who were saying, oh, I don't know that. Oh, that's really good. You were able to explain that. So I think there's something about, be curious, but also don't doubt your contribution, because we absolutely can make a difference. And there's lots of really good examples, both here today and in the general sort of aspects of the profession where people are doing a great job. We just need to be a little bit more confident about sharing that. Thank you.
Thanks so much, Jenny. We do suddenly get kicked out on the hour, so if I get cut in half, don't worry about it. Please do your feedback forms. We do listen to your feedback and act on it, and do carry on that discussion in the communities platform as well. Thank you so much to everybody for joining us today, and huge thanks to all our panelists. It's been really inspiring.